I Happy Monday, everyone, and welcome. You're listening to Off the Rez Podcast. My name is Piri, or future Dr. Greg, your friendly epidemiologist or data warrior, as I like to refer to myself. I want to do a shout out to my sister Shannon and wish her a happy birthday. I hope you have a great day. Also, please like this video and subscribe to the channel, as well as keep on sharing with everyone you know. We're building momentum, and I really do appreciate all the comments, emails, and phone calls of support that you've sent to me. Also, if there is a topic that you would like me to cover, or if you have questions, you can leave it in the comments, or you can email me at jpwhite, like the color, at strengtheningnativeConnections.org. Today, we're going to be talking about data. This is my passion and what gets me really excited. As I mentioned in an earlier podcast, I earned my master's in public health from University of California, San Diego School of Medicine. And today I'm going to nerd out. But don't worry, I'm going to use the KISS concept as coined by the great female entrepreneur Mary Kay Ash said, keep it simple, sweetie. So what is data? Data is basically raw information. It can be numbers like 25, 100, decimal of 3.14, or even percentages. It can be words such as names of people or places. It can be measurements such as height, temperature, or weight. But it can also be images, photos, videos, sounds, and recordings. All of these are data that are collected so that they can be studied or used. Data is basic building blocks of knowledge. It helps us understand things and make decisions. Indigenous people have been using data since time immemorial. This literally means from the beginning. We tracked data through the sun, moon, and stars, even seasons, to know when to move, where to hunt, and what plants we could eat. We tracked data on plants as medicine and what worked for different ailments, so this is nothing new to us. You too use data every day to make informed decisions about your own life. For example, those of you who drove your car today, you probably glanced down at the gas gauge. Was your car full of gas? Maybe, and that's great. Maybe it was half full and you decided to wait to get gas. Or maybe it was on E and you needed to buy it immediately. Then you had to analyze in your brain how much you could afford from your budget and where you were going to buy it and at what price. We use data every day. It's that simple. As an epidemiologist, I'm a scientist who studies health and disease in groups of people, populations. In simple terms, I look at what causes disease, how diseases are spread, who is affected, and how to prevent and control them. I collect and analyze health data. I look for patterns, where, when, and how people get sick. And then I make recommendations on how to stop disease spread and improve public health. For example, during an outbreak, I investigated where illness starts, identify who is at risk, and suggest actions like vaccinations or safety guidelines, or make recommendations on public health laws or policy. It is from this perspective that I want to approach tribal data. There's a lot of talk about data, especially these data centers are being built. But over the years, in both my academic and professional experience, I want to share that I've come to realize people who work with data and those of us who just use Google continually push the narrative that American Indians and Alaskan Natives have the worst health outcomes. From chronic disease such as heart disease and stroke, cancer, diabetes, and kidney disease, to infectious disease showing that AIANs have higher rates of tuberculosis, HIV/AIDS, Hep B and C, and others. We've all heard it. You get the picture. You're currently living in this world of misinformation. And personally, I'm sick and tired of being told we are sick. This has not been my experience, nor is it what I've seen when working with our communities across the nation. I believe this is intentional. I believe it is to keep us sick. If you tell someone something long enough, they will believe it. And unfortunately, this has been built in the system of public health, research, and academic institutes of health, who continually perpetuate this narrative that is so damaging to Indigenous peoples in our communities. This is exactly why I believe we need to use tribal sovereignty and data sovereignty to collect and analyze tribal-specific data so tribal leaders can make informed decisions to benefit their enrolled members. And as we know, those living off the res are the majority of your people. So those decisions must include allocation of resources to include the majority of your tribe off the res. The data you Indigenous public health workers have been using might be from the CDC or the ACS, American Community Survey, or BRFIS, the Behavioral Risk Factor Survey. The BRFIS is a nationwide system of telephone surveys conducted in all 50 states and some U.S. territories, focusing on adults age 18 or older. The BRFIS tracks data such as health behaviors such as smoking, exercise, diet, and alcohol use, chronic diseases like diabetes, heart disease, and asthma, also preventative care, including vaccinations and screenings, and then access to health care. It's important because it helps researchers and governments understand health trends and use to plan public health programs and policies. It also tracks risk factors that lead to disease. Some of you may use NHANES, which stands for the National Health and Nutrition Examination Survey, another national survey, but it's done on both adults and children in the US, and it's designed to assess health and nutritional status of our populations. It's done by interviews, questions about health, diet, and lifestyle, physical exams, including height, weight, and blood pressure, but also laboratory tests such as blood, urine, and other samples. Again, it's conducted by the US Census Bureau and is conducted every year, not just once every 10 years. And it collects data from millions of households across the US. The ACS is another survey that you might use, the American Community Survey. It provides detailed information about demographics such as age, race, and household type, economic factors like income, jobs, and poverty rates, social characteristics, which include education, languages spoken, and citizenship, along with housing information, whether people rent, their home values, the number of rooms in their homes, and utilities. It gives a detailed picture of communities and how they're changing. And again, it helps governments and organizations plan schools, roads, and hospitals, how they allocate funding and make policy decisions. But all of this data, in my opinion, is bad. While they have good intentions and might work for Western biomedical research or support community health programs, in my professional opinion, they are problematic because the data collected is based off of race. And as I mentioned earlier, we are not a race. This creates a problem of misrepresenting and misinterpretation of health outcomes for tribal peoples because it is self-reported. Anyone can say that they are Native, but in actuality, they are not federally recognized citizens of tribal nations. so they do not pertain to our tribal specific communities. And I want to tell you a story about a data symposium that I went to. And they had invited the state health department representatives to come and give a presentation. And those workers chose to present the current data on HIV rates. Now, you might not think that that's a big deal, but in this case, they reported that there were almost 30 cases of new cases of HIV in tribal communities within the state. And when I asked which tribes or who were those people, obviously it was protected health information and they couldn't tell me who the people were. But then they actually said, well, we don't collect tribal specific data. We just know that the people self-identified as American Indian or Alaskan Native. So I pushed back again and I said, so you don't know if those people actually are in the tribes within this state? And they said, no, we don't. So if you were a tribal leader and your people or public health workers had obtained that HIV data stating that there were almost 30 cases of HIV on American Indians in your state, you might allocate resources to help fight the prevention or spread of the disease. But in actuality, it may not have anything to do with your tribe. Those people may not have any connection to your tribe or your tribal community whatsoever. So you can immediately see how that would be problematic. You might also hear that there isn't any data on Indigenous people and that we're an asterisk group, meaning there isn't enough of us to run a statistical analysis. This is why I want tribal leadership and those working in public health in and for our communities to take action to start collecting our own data. As I mentioned, I worked as an epidemiologist and lead outbreak investigator during COVID-19. One of my many responsibilities was to call the COVID outbreaks 3 times a week, covering the entire county of San Diego. This included a population of over 3.2 million people, with over 93,000 businesses, 1.2 million households, covering over 42,000 square miles of land. And I did it all with Excel. It doesn't have to be complicated. It can be with paper and pencil. I also want to highlight data sovereignty and what that means. Data sovereignty means the tribe owns their own data. The tribe decides how it is collected and by whom. They should say how it is analyzed and when and where those results are shared, if ever, within the community or outside. This could be in newsletters, social media, peer-reviewed journals, publications, or only in tribal council or business committee meetings, however your tribe is structured or whatever your tribe calls their membership meetings. And it can be done as often as you want. It can be done weekly, monthly, quarterly, or even annually. It's how your tribe decides. So how can you do this? It reminds me of Lord of the Rings, the data, like the ring when Gandalf tells Frodo, keep it secret, keep it safe. Well, we're also going to use the KISS concept and keep it simple, sweetie. Print those surveys, print the Burfus, print NHANES, print the ACS. They're all publicly available online. And then take it to your leadership, take it to your public health workers and tweak it to fit your tribe's priorities. Make it your own, personalize it, make it obtain the information and collect the data that you want collected. You don't have to reinvent it. You can use the foundation of those surveys in your community for your tribal populations. Many of those surveys are done via phone. Have your public health workers Call your tribe enrolled citizens and ask them the questions. If you have enrollment officers, they're already collecting data on your membership. You know who your people are. And as I've mentioned, most of us live off the res, and you need to be including us in that data to make those decisions on how to allocate the resources to include us. Something else I want to talk about are tribal epidemiology centers, or TECs, which are tribally operated public health organizations that support the health of American Indian and Alaska Native communities. They focus on collecting, analyzing, and using health data to help identify disease patterns and health risks. Their goal should be and is to improve health outcomes and reduce health disparities for the tribal nations that they serve. The Indian Healthcare Improvement Act in 1992 authorized the creation of the TECs at the federal level. In 2010, reauthorization of the Affordable Care Act officially designated TECs as public health authorities. This means being a public health authority that the TEC can access and use protected health information data that is collected by government and other public health entities to do public health work to help the tribes that they serve. They're supposed to be working in partnership with tribes and providing services through core public health functions. This might include collection and monitor of health data for tracking diseases and trends, evaluating health programs and systems, identifying priority health issues for the tribes, again, that they serve, recommend services and improvements, provide technical assistance to tribal health programs, conduct disease surveillance and outbreak response, and support prevention and health promotion efforts. And this is done on behalf of tribes when asked, meaning the tribes have to ask the TECs for help. Now, I want to tell a tale of caution when using TECs. I had the privilege of working for a TEC briefly as an epidemiologist. And it was clear from the day that I started that most of the employees were not Native. And they actually had no idea what it meant to be Indigenous and no understanding of federal recognition or tribal identity, let alone the cards that we had to carry. Also, they were not educated as epidemiologists, even though they held the title. They had not gone to school or had any formal epidemiology training. They also did not have any cultural understanding of tribal communities or what it was like to work with tribes or respect for tribal sovereignty or data sovereignty. This was very disheartening to me. I also realized early on that leadership who had been in place for decades were inappropriate in speaking of the tribes that they served and had been in these positions and had never, ever gone out into community to build the relationships with the tribes that they were tasked and serving and working for and being funded for. Neither had they had taken their employees into community. So this is why, in particular, I recommend tribes do it themselves. You need to hire appropriate, educated Indigenous scholars. There's lots of us out here. Even if you can't do it on a full-time basis, a lot of us do contract work to assist tribes in helping meet their priorities to their communities. You need to ask tough questions in the interview process. This includes, do you understand tribal sovereignty and data sovereignty? What do you know about our tribal structure and policies and protocols? How do you incorporate data sovereignty and ethics into your work? How will you work with tribal leadership and our public health workers to build capacity to keep this work ongoing so that we can do it ourselves eventually? And finally, I just want to make sure that you guys are safe in storing the data. Did you know that techs receive data from IHS on flash drives? So it doesn't have to be some expensive IT fiasco with all this crazy cloud services. And I highly recommend you don't use the cloud. If anything, buy a flash drive or buy an external hard drive. I buy an external hard drive for every project that I work on because even though I might use it, the tribe owns it. And when I am done working with them, they get the hard drive. And they're fairly inexpensive. And to meet research protocols and data security, all I suggest is that you keep it in a locked cabinet or a locked desk drawer in a locked office. That means that it's under lock and key twice, and it limits access to unauthorized persons. And this is something that places like the NIH, National Institute for Health, or other research organizations will want to make sure that you're doing. But again, keep it simple. It doesn't have to be complicated. And the reason why I caution against clouds is because if it's not a tribal infrastructure and your specific cloud, even if you're purchasing it from someone else that says you have authorization and autonomy over it, do you really? Can it be hacked? Are they making copies? I can't tell you how many times I have had outside researchers, outside data collectors who have made copies and kept the data and used it for themselves. That is an invasion and a direct violation of tribal sovereignty and data sovereignty. And it's up to us to make sure that our people's data is protected and is kept sacred. I know we can take action and implement change on how we can collect Indigenous data to help reflect the accurate health status in our tribal communities. Please know that help is available. And if you want, email me, ask me questions. Again, my email is jpwhite@strengtheningnativeConnections.org. I hope today's episode empowers you in working with data and that it's not as scary as you think. Keep it simple. Keep it easy. Just start doing it. And as always, sending love, light, and health to you and all. Thank you again for listening. Until next time.